Good evening, everyone, and welcome to the August Member Appreciation Plus webinar. Very happy to have you all with us this evening. I'm Amy Lamb, have the privilege of serving as your AOTA President. Tonight we're going to be talking about how occupational therapy practitioners can prepare for the new skilled nursing facility payment model. We have two of our experts here joining me this evening to talk about that. Jennifer Bogenrief is part of our regulatory staff and is going to be introducing the model and talking about the ins and outs of it. Natalie Leland is one of the experts that we've been using with CMS and has been very integral to our discussions in terms of how do we roll this out and connecting the lines between the new payment model and opportunities that we may have in practice. And then I'll be also speaking this evening about things that practitioners can do every day in their clinical settings to help be able to bring this home. Just a couple of housekeeping tips. I just want to let everybody know that you might have noticed the new webinar platform if this is your first time joining us back in a while. One of the benefits is that now your CE certificates are automatically generated following the webinar, so there's no wait time, which is awesome. However, you need to stay on for the entire webinar until you see the pop-up screen that says the webinar is now over. Please do not exit the webinar prior to seeing that pop-up screen, or you won't get the email that contains your link to your CE certificate. So just wanted you to all be aware of that so that you don't miss the opportunity to earn your free CE. Tonight, as I kind of introduced already, we're really hoping to have you walk away with an overview of the main provisions of the CMS new Medicare Part A Skilled Nursing Facility PPS payment model, and it's called PPDM, or the Patient-Driven Payment Model. How to be able to prepare for it before it goes into effect on October 1st of 2019. We feel like it's important for us to get prepared and ready for it before that date. And then finally, to really be able to see what you can do to ensure that OT's role in the skilled nursing facility will continue to be a critical contribution to achieving patient outcomes. We're going to have a good amount of time for questions at the end, and so please don't hesitate to do that. Just type in your questions and we'll be taking those at the end of the presentation this evening. Also, last thing, I just wanted to let people know that if you want to download the PowerPoint, it can be found underneath the event resources. And just a reminder to use that Ask a Question pod to be able to share your questions as we're going throughout, and then we'll answer those at the end. And with that, I'm going to turn it over to you, Jennifer.
Hi, everybody. This is Jennifer Bogenrief. I'm the Assistant Director of Regulatory Affairs at AOTA. And we're kind of going to just dive right in. I want to give you a quick overview so that you have enough information about the new PDPM so that you'll understand the really important points that Natalie and Amy are going to make after I talk about the model. There's a long history to it, and talking about why CMS did this and how it came about. There's been a push for this to shift away from payment based on the amount of therapy minutes and the volume of services for many years, actually. Congress, the Medicare Payment Advisory Commission, which is MedPAC, and the Health and Human Services Office of the Inspector General have all highlighted the opportunities for fraud and abuse that exist in the current resource utilization groups, version 4, which is the RUG-4 system, because payment is based on the amount of therapy and nursing provided to a patient instead of that patient's individual characteristics and their care needs. AOTA has been involved from the beginning. The CMS contractor Acumen began holding technical expert panels in February of 2015. There were 4 TEPs total, and AOTA was represented by Dr. Natalie Leland on the 3 TEPs that were relevant to us, and those occurred in February 2015, June, and October of 2016. There was another TEP that covered nursing and non-therapy ancillary services that was held in November of 2015, and there are more details available about that. There's a CMS SNF PPS payment model research webpage, and you can always email regulatory@aota.org if you're interested in getting more information about that. CMS actually issued an advance notice of proposed rulemaking last year for what they called the draft resident classification system version 1. It was RCS1, if that might ring a bell to you. That was issued in May of 2017. It wasn't technically a proposed rule, but it was a proposal saying, it was a notice of proposal saying this is what we're thinking about doing from CMS. And there was widespread stakeholder opposition to RCS1. AOTA developed a template letter that a lot of OT practitioners used to oppose the RCS1 by submitting comments to CMS. And we know this because we were in a meeting with CMS in January, and they specifically said that they heard from a lot of OTs, and they heard us loud and clear, which is a great thing. But people used those letters to, there were some safeguards that we were hoping to get, and we were successful in getting some. CMS issued the proposed, so they didn't, the RCS1 was not really a proposal. It was just this is what we're thinking of doing, and we were expecting something to come out this spring, and it did. CMS issued the proposed patient-driven payment model, or PDPM, in this SNF PPS proposed rule on April 27th, and the comments were due at the end of June. And AOTA provided another template letter for OT practitioners to support some of the added protections that we were able to convince CMS to include, as well as to urge CMS to recognize the full scope of occupational therapy's role in SNF, specifically regarding cognition and swallowing. CMS received quite a few comments. They got 294 comments, and the final rule was published very quickly on August 8th with a few changes, but the big basics remained the same. PDPM includes some safeguards, as I said, such as reporting the total therapy minutes by discipline. So for PT, OT, and speech, they each report their total therapy minutes at the discharge on MDS Section O. That is a little bit of a difference because all of the extra assessments are going away, so there will be admission and discharge assessments. There's also a 25% combined limit on group and concurrent therapy, and we feel like those protections are really important in order to ensure patient access to individual therapy, which CMS strongly supports over group or concurrent therapy, and also tracking the therapy minutes in a SNF so that they can maybe compare. They do plan to compare therapy utilization once PDPM takes effect versus the therapy utilization that we have been experiencing under RUG 4. CMS did not include cognition or comorbidities in the OT or PT components, and I'll talk about those components in a second. And they didn't specifically recognize OT's role in swallowing disorders, and I will talk a little bit about that later. But their rationale was that the data didn't support those areas for inclusion in the model. They left the door open so that items could be added in the future if it's supported by data. And so that really sends a strong message that if OT practitioners can change care practices by providing, documenting, and reporting these critical areas where they play a really important role, and the future data shows that strong impact on OT utilization, then CMS will be able to add those new items to the OT component. So got a little bit ahead talking about the components, but we're going to go kind of break it down a little bit and explain how the PDPM is designed. Basically, there are 6 components for the Medicare Part A SNF payment. There's OT, PT, speech, nursing, non-therapy ancillary, and the non-case mix portion, and all of that contributes to the facility daily rate. I did want to mention that AOTA had advocated to get the OT and PT classifications separated. They were in RCS1, they were combined. And we felt that that would put us at risk of, that there might be a risk of inappropriate substitution. of OT for PT or PT for OT. And so we felt it was important to maintain the distinct value of occupational therapy by getting those components separate. And a lot of stakeholders agreed with us and supported those comments, and CMS ended up agreeing as well. So the OT component is based on, it's one of the 6 components, like I said, that make up the daily rate, and it's based on the primary clinical reason for the SNF stay, which is called the clinical category, as well as the patient's functional score. The clinical category is based on the ICD-10 code from the MDS I-8000 item. And that item hasn't been used for payment purposes in the past, so SNFs will be paying more attention to that item under PDPM. And then also, if the patient had an inpatient surgical procedure during their hospital stay, that will be reflected in a modified MDS item J2000, which CMS is developing. And you don't need to memorize those items necessarily. It's just important to become familiar with kind of the new things that people will be talking about, your administrators will be talking about, and so we wanted to highlight that. The function score is the other piece, and I'm going to talk about that in a second. I want to give a little bit more explanation of the clinical categories next. So for the OT classification, the items on the left column, are the PDPM clinical categories that CMS developed. And they started with that longer list, and then they ended up collapsing the list into 4 different PDPM clinical categories that will be used for both the PT clinical category and the OT clinical category. I took this table from the CMS final rule itself. It happens to be table 15 if you are so inclined to look at that monster of a final rule. But it's important to understand that even though it says in that table that it's the PT and OT clinical category, the PT component and the OT components are separate. But so the MDS item I-8000 is where you get that clinical category from, and then you use that to select one of these 4 categories on the right-hand side of the table, and that's major joint replacement or spinal surgery, non-orthopedic surgery and acute neurologic, other orthopedic or medical management. And you might notice that there are several items that if you look across to the previous side of the table, the expanded categories, medical management is connected to quite a few, and there are some big categories there. That was a point of discussion during the TEP meetings in developing the model, and it might mean that more than 50% of the patients could be in the medical management category, and that is something that has been recognized, so that wouldn't necessarily be inappropriate. It's really, we might see differences based on what kind of patient populations a skilled nursing facility has. You can tell from the categories what those might be, how those might be different. So the function score is based on section GG, and hopefully you've heard a little bit about section GG. If you know RUG 4 that is currently used, they use section G, the functional status ADL score, to determine the patient's functional score under RUG 4. The PDPM will use section GG, functional abilities and goals data for OT function score and the PT function score. And if you aren't familiar with section GG yet, it's really important that you become familiar. And I've included this table, it's table 18 from the final rule, and it lists the items, and you would probably pay close attention to the self-care items. But then there's the scoring column, and there are very specific guidelines for scoring. And we have more information about how to advocate for the value of OT with the self-care measures and links to further training from CMS on how to fill out section GG, how to do the scoring. That information is available on our website at www.aota.org/care, C-A-R-E. From this list, you can tell that the self-care items, eating, oral hygiene, and toileting hygiene, as well as the mobility items, are important areas for OT as well as PT, and they will be part of the formula that's used to determine a patient's daily rate, so they're even more important under PDPM. But it's important to keep in mind that Section GG is not limited to OT or PT. Other practitioners can also complete this part of the MDS, so it's really important that OT practitioners highlight their role in these areas and advocate for themselves to protect their role. And as I said, you can go to www.aota.org/care for more information about that. I also want to recommend that you watch for the draft RAI manual. That's the Resident Assessment Instrument Manual that's connected to the MDS, and that will provide a lot more guidance, and AOTA will be putting out notifications when that is available. I encourage you to become very familiar with what role you can play with the MDS because that will help highlight the need for OT to contribute to PDPM and help reach the patient, the desired patient outcomes. So what's really different with PDPM? It replaces RUG 4, so there won't be any more thresholds. You won't have to try to get the magic number of 720 minutes of therapy. It focuses on clinically relevant factors and patient characteristics as the basis for patient classification. So the patient is really supposed to be at the center. And thinking about the areas that I mentioned earlier, that the areas that CMS did not include for OT at this time, cognition, including mild cognitive impairment, also swallowing disorders, as well as comorbidities, they weren't included because the data doesn't support OT's role right now. But CMS indicated that cognition should be considered in future system refinements. There are some measure development that is happening now, especially with cognition, and AOTA and some of our member experts have been involved, and we remain optimistic that might get changed so that our cognition will be part of the OT component. But because of that possibility, it's critical that OT practitioners target their services to individual patient needs and document what you're doing and why. We have heard from CMS that things aren't documented and reported, and so if you're addressing something with a patient but you don't document it, then to CMS and the Medicare administrative contractors who are reviewing claims, it's as if it never happened. So you have to claim what you're doing and how it impacts patient outcomes. And it's also really good to hear from CMS when we meet with them that they are very supportive of the therapist using their clinical judgment to determine patient care, and they want to see that documented. Keep in mind that this is a major change, and we know that. It's going to require OT practitioners to think differently, and it's an opportunity really to focus on what matters to the patient rather than just getting the minute. And with that, I'm going to turn it over to Natalie.
Great, thanks, Jen. So I know this from talking to a lot of people in the community in the last few weeks since this has come out. There has been a lot of concern and anxiety, and part of what we wanted to do tonight was to address some of those concerns, but also frame this around some opportunity. And so I wanted to bring in a discussion about kind of the bigger context in which this is happening. I know Jen talked a little bit about it, but I want to anchor it even more in what this means in a policy context and what our opportunities are. So since the Affordable Care Act was passed, there has been a long-standing push to transition payment, not just in skilled nursing, but across the entire healthcare continuum from a fee-for-service model to a value-based payment model. And what that means is getting away from paying based on the number of minutes or the volume of tests for physicians, but for getting away from the volume of services to really incentivizing high-quality care. And that has really operationalized in a variety of ways. And in this image on this slide, what we wanted to try and convey is that while the PDPM on its own looks like it's taken away that incentive to say that, okay, OT is going to bring in X amount of money because they're delivering so many minutes of therapy, we just need to shift our frame of mind to think about what is OT's role in the broader value initiative that is going across our entire healthcare system. Within post-acute care, we have the IMPACT Act, which is really driving the measure of quality and the measures that have been identified in the IMPACT Act. Some of them are readmissions, community discharge, skin integrity, medication reconciliation, function and change in function, as well as major falls, accidental falls, the falls with an injury. And I think when I look at each of those, having practiced in the SNF, I know the unique value of what OT can do in each of those outcomes when we think about what is something that an OT practitioner delivers to a patient to prevent falls, to ensure that they get home and stay home. And I think that's where the big shift is going to be. And those are all things that we can start to do now. So in addition to the context of the IMPACT Act and where those quality measures are being rolled out, we then think about the SNF value-based purchasing program. So as we think about, again, not just reporting on the quality measures as our facilities are starting to do, but CMS is starting to link how facilities are performing on certain measures to either an additional payment, or if they're performing very poorly, even requiring facilities to pay a penalty. And as occupational therapy practitioners, if we are, demonstrating our value and operating at the top of our license as part of this interdisciplinary team, we can help drive achievement in high-performing outcomes. There's also the SNF quality reporting program, which you can think about the 5-star, the Nursing Home Compare website, which we can all go on and look at the facilities we currently work in or have worked in to see how is our facility performing? What do our clients, when they're trying to look at our facility, what does that look like? How do we look like compared to the national average, and how do we look compared to our closest competitors? So all of this transition towards value is happening simultaneously with the PDPM. And I will tell you, the one comforting thing that I heard on many of these conversations with CMS around the rollout of this program is that while the PDPM model is the foundation, it is the value-based initiatives that we have on this slide that are going to ensure that are going to be the checks and balances to this payment program. And I will tell you, that's been one of the comforting things for me, as I've had many concerns over the many TEPs that we've been on and worried about what patients are going to be able to get the care they need, and ensuring that our therapists are going to be in those facilities to provide that care. So when we think about those outcome measures from the IMPACT Act, I think what we need to think about as occupational therapy practitioners is not only what do we do with each patient, but how can we demonstrate that value? And we need to think about how do we demonstrate that value in the context of minimizing the risk of those poor outcomes, such as major falls, and how can we show that we can be a leader in preventing or promoting the getting home and staying home, or the community discharge measure. I think we have a very unique role, a very strong role to play, and it's just making sure that not only do we deliver it, but as Jen said, we document it, and we have the evidence that shows that we have that value to play. And I just wanted to throw in a quote from Avis Donabedian that the most direct way for us to improve outcomes at a system level is to target the care that we provide. So what, again, are those discrete actions that we as OTs are best situated to deliver, and how can we ensure that we deliver them on a consistent basis across patients to optimize those patient outcomes. So again, just thinking about our value, and I know this can be a bit jargony, and I think Amy is going to step in a minute and give us some context for this, but thinking about those very concrete actions. So when we go see Mr. Jones or Mrs. Smith tomorrow and are working with them, what are the key practices that we know are evidence-based occupational therapy interventions that we know are going to help them get home and stay home? And can we make sure that we don't just give it to that client, but all the other similar clients who would also benefit from that intervention? And the more we can ensure that we're delivering this best practice to our clients, we can not only demonstrate our value to the rest of our care team, but to the facilities and the health system and to CMS to make those changes that Jen has talked about. And with that, I will pass it on to Amy.
Thanks, Natalie, and thank you, Jen. So when I initially asked Jen and Natalie to join me tonight to be able to talk about this for the members of AOTA, it was really because we're starting to already hear that things are happening within skilled nursing facilities and within the settings, and that people are talking about implementation. And we want to share this message with you, give you an opportunity to also share with us what you're hearing from your facilities, and really be able to try and position the profession to be able to make sure that we are at the key tables that we need to be at to be able to articulate our values, that we're taking the opportunity to demonstrate it and document it. So there's a couple of things that I'm going to circle back to in terms of what both Jennifer and Natalie have talked about as well. I think one of the things, too, is I've been having some discussions with some of my colleagues who are in administrative positions within skilled nursing facilities or organizations that staff them, is that small actions can have a big and lasting impact, and that we need to really think about how do we take some of those small actions daily to be able to make a difference in this system. And this is the time from today through October of 2019, or up to October of 2019, is really the time for occupational therapy to be showing our value. And so this is when those small actions can really make a big impact for us as we move forward. So some of you, this is not new. We've been talking at AOTA for several years about occupational therapy's distinct value. And one of the pieces is that we have to be able to articulate what is our value, what is distinctly different about occupational therapy than other professions that are also working in skilled nursing facilities. We have to be articulating that distinct value to clients when we're working with them so that they understand what we're doing and how it relates to getting them back to their everyday life. We have to be doing the same thing for family members and caregivers, articulating that value, showing them how what we're doing in occupational therapy is getting them back. We need to make sure that we're speaking up at daily meetings or any sort of opportunity that we have within the facility to be able to articulate how occupational therapy is helping the facility to be able to improve their quality measures, to be able to improve their outcomes, get patients home as quickly as possible. MPS coordinators are another group in terms of we need to be targeting to really articulate what the distinct value is of occupational therapy, and then facility administration at large as well would be included in that list. So one of the first things that we can do is really focus on making sure that we're sharing that message and that we're sharing it widely with people so that they can hear what occupational therapy is bringing to the team. The next piece is we can't just talk about it, we have to do it. And so it's that piece about demonstrating our distinct value within our daily work and practice. So using the standardized assessments to show effectiveness of treatment and having client-centered outcomes. This is critical at this particular juncture because this is the time where we're really able to position ourselves as this model is rolling out and will be implemented. Making sure that our interventions are evidence-based. what's going to get people out of that facility as quickly as possible. And oftentimes it is things like activities of daily living, the IADLs, maybe there's caregiver training or medication management that needs to happen. This is perfectly fit within occupational therapy's bucket, and it really is an opportunity for us to be able to showcase our distinct value and what we do differently. It's also an opportunity for us to be able to really practice again at the top of our license and be able to show how occupational therapy is a critical part of the team, and that the clients really need this service to be able to get them out as quickly as possible and get them to home. Thinking about cognitive decline or behavioral challenges that clients might be experiencing and how we can meet that need. And I know I've seen some of the questions coming in with concerns about occupational therapy being able to use the cognitive code. So we'll definitely address that in the Q&A part tonight. I think that there's a really critical piece here as we can drill in to show how occupational therapy can address cognitive changes differently. And so it's a great opportunity for us to show, again, and demonstrate our distinct value. So it's good to talk about it, and we have to be doing it, but we also have to be documenting it. If it's not documented, it didn't happen. So we need to make sure that those goals that we create are client-centered and that that plan of care is anchored in the everyday life, because that's what links to the distinct value of occupational therapy. We need to make sure that we're capturing the skill of occupational therapy, and as Jen talked about earlier, CMS is wanting to see your clinical judgment, and they're wanting to hear from you as the clinician about what this client needs and what is the best plan of care for them. So this is a great opportunity for you to really capture the skill of the occupational therapy professional and really tell the client's story so that they understand that without occupational therapy, this client's story would not perhaps be ending in the same way as it is. But when you're involved, it allows us to get people to that home environment faster. So I again want to circle back to this idea that small actions and a lot of people, which we have a good number of people on this call tonight, and hopefully more will listen to the recording, can really result in big change. And I know how scary it can be when new payment systems roll out. I've went through this in my career, as I know many of you on the phone probably have already. We've already been through this, and so the great thing is that we've learned from previous experience, and so we can take that knowledge and move it forward. And I think this idea of the small actions that each and every one of us can take in our clinical practice, when we multiply that by all of the members within AOTA, can really result in big and meaningful change for the clients who are in skilled nursing facilities, the facilities themselves, for the occupational therapy profession, and really to just help to be able to move that needle forward as we're working to advance quality. With that, I know that questions have been coming in, and so Jennifer, Natalie, and myself are going to go ahead and start taking questions now. So if you have more questions, please feel free to send them in, and we'll keep answering them. We wanted to leave a lot of time for Q&A this evening. So Jen, do you want to go ahead and take a question, and then we can go to Natalie and back and forth?
Sure. I see that there's a note that the RAI manual for 2019 came out last week, and I believe that's fiscal year 2019. So that's the RAI manual that's effective October 1st, 2018. I do expect that the next iteration of the RAI manual that will come out next year, likely sometime, will have more details. There are some bigger issues that I didn't really talk about because they're not specific to therapy, but there's some other issues included within PDPM that are very different and will require a lot of guidance from CMS. So that will likely be included in the newer version of the RAI manual once they're able to make those changes.
Great. Oh, so one of the questions I got was, how involved can OT be at admission with Section GG within the first 3 days in capturing usual performance? I can see more input at discharge. From my knowledge, and Jen, please correct me if I'm wrong, at this point we do not have that level of detail on who is expected to do Section GG on the admission MDS. So I don't feel comfortable speaking on what I would, what we know will happen since it is so early. I think this is, in a perfect world, I can say, trying to build relationships with the MDS coordinator or the person in your facility now to ensure that, they recognize the perspective that you bring when capturing the Section GG items, because again, if we connect it to the quality and value-based initiatives, one of the Impact Act quality reporting measures is change in function. So that's a place where we can help the facilities in terms of capturing that change.
And I have, Natalie, this is Jen. I just wanted to say real quick, we've been hearing a lot of conversation about usual performance and what that means, and there's some frustration with that, I think, because it's not super clear. So I would watch for more information. We've urged CMS to do training. I know that they plan to do that. I don't know the timeline. They haven't given that yet, but any chance that you have to get training on Section GG, I would take it, because you're going to hear more and more. And the other thing to note is that it's important to think about where you're getting that information. So it sometimes is hard to know until you hear it, but getting whatever you can from CMS, AOTA will be providing or at least posting good sources of information so that you'll know where to go to get that.
Great. Thanks to both of you. So one of the questions that's come in, and this one's come in a couple of times, is around the job market. And do we feel that this change will cause a decrease in jobs, both OT and PT, within the skilled nursing facilities settings, because it won't be minute driven? And, I think that it's a tough question to answer precisely and say exactly what's going to happen with the job market, because, my crystal ball has gotten very, very fuzzy in the recent years, and there's so many changes happening within the system that, my crystal ball has turned into more of a bouncy ball these days. So I think the most important thing that we need to do is we need to really emphasize that piece about showing our value within these settings today. And I think that as long as we can really show that occupational therapy is a valuable service, that people are going to pay for it. So it is going to be something that they are going to say, we can't do without this service, because without occupational therapy, people are going to have a longer length of stay. They're going to be here longer. We're not going to be able to get them home. They're not going to be able to be as independent with their family. They're not going to be able to manage what they need to do every day. Those are the messages and the pieces that we need to be driving home each and every day. And I think that as long as we can really activate the workforce to really empower everyone who's working in these settings to be showing our value, to be articulating it, documenting it, I'm confident that we're going to be fine as we navigate this, because people will see our value. So it's really hard to predict exactly what the job market will do. It's also, there's a lot of different variables that come into play, and as Natalie talked about, this is not just happening in skilled nursing facilities where we're seeing this movement towards value-based payment, but we're seeing it in all the parts of the healthcare sector as well. And so there's just a lot of different variables that could come together, but that's really why tonight we wanted to have this discussion. And it might seem early for some people to be talking about something that's coming in October of 2019, but October of 2019 is really too late. We need to be activating now and making sure that all of our occupational therapy practitioners in skilled nursing facilities are really showing and demonstrating the value of OT so that we can make sure that come October of 19, we're well positioned.
Jen, do you want to go next with your next question?
Sure. Let's see, there's a question. How will they categorize patients that may have two pertinent categories for admission? For example, orthopedic surgery with acute respiratory failure. Will they only include the first listed diagnosis? And that really, I think that this is where there are going to be some judgment calls, and this also might be a place where that opens up the possibility of some manipulation by the skilled nursing facility in making sure that they're choosing certain diagnoses as the primary that would be included on that MDS item I-8000, so that that would be what's used to choose the primary category and then maybe get a higher payment. Skilled nursing facilities are already figuring out how they're going to get higher payment for certain types of patients. And so I don't know how to answer that, except that it depends on what's determined to be the primary reason for the SNF stay. And so it really depends on what that is. And it will be just one that's used for the primary reason. For OT and PT, they're not considering comorbidities, which is very unfortunate, and it was not something we agreed with. We fought that through the whole process. But they will be looking at utilization and seeing what types of conditions have an impact on the care needs, and there may be some refinements along the way. So it is important to just document completely and accurately so that appropriate changes can be made in the future.
Thanks, Jen. So the next question I got was, a lot of SNFs I work in are currently doing weekend therapy to get the minutes. Do you feel it will return to a Monday to Friday model or continue to include weekend therapy? So based on this model alone, they don't go into that level of detail. But again, if we think about that broader value and performance context, what I think we need to think about is the push for preferred provider relationships. There's been a lot of research in the last few years about hospitals being very purposeful on the SNFs that they are partnering with to ensure that they're getting their optimal outcomes, because they're held for outcomes 30 days post-discharge from their facility, as well as accountable care organizations having incentives as well to get patients through the system and back to the community, which to me says that they don't want to be paying for someone to be in a facility all weekend without getting therapy if that's what they're there for. So I think it might be interpreted in many ways, but if you think about that broader health system perspective, I think that those are still some of the driving factors which may influence having access on the weekend so that they're not paying for services.
Great, thanks, Natalie. One of the questions that came in is about occupational therapy assistant services, and there are some people who have heard that OTA services will not be reimbursed at the same rate as OT, and is this something AOTA is looking into? Yeah, so absolutely, AOTA is aware of this. It emerged as a part of the Balanced Budget Act of 2018 that passed earlier this year, where they are proposing a 15% payment reduction for OTA services. And this is something that AOTA is aware of. We are actively working on it. We have a work group doing some very focused work around it right now. We're really working to try and create opportunities to really study the impact of what that kind of change might mean for underserved areas such as rural populations and those sorts of pieces. So it absolutely is something that AOTA is working on currently, and you're going to be seeing and hearing much more about it in the coming weeks and months. So I would definitely encourage you to stay connected to us, because there's a lot that's evolving on all of these issues, and that's one that is very high on our AOTA policy team's work these days. So great question.
And not
Jen,
this is Jen,
go ahead.
Not to make it more complicated, but that is under Medicare Part B. PDPM is under Medicare Part A, so I just want to make that distinction. I understand that SNF has Medicare A and Medicare B patients all mixed together, so it doesn't really matter, but that there is that distinction, but it is important to be aware of it. It's still an important issue, and staff in the office is talking about it very frequently.
Yeah, absolutely. So, Jen, I know you have quite a list of questions probably. So do you want to take a couple of them and then let us know when you want to pass it to Natalie and then myself?
Sure. There's a question about when you say that cognition and swallowing are not part of OT in the system, do you mean that residents admitted for those clinical categories don't qualify for OT? And I appreciate this question. I want to make a note that cognition and swallowing aren't considered clinical categories in PDPM, but the main point in answering this question is that CMS is not dictating what type of care a patient should receive, and this is where the opportunity lies for OT, is that you should be identifying the care needs of the patient and addressing those needs. It doesn't necessarily matter what clinical category they're in, their needs should be met. And it's frustrating to us to not see things kind of laid out in a way that makes sense and it's clear that we can know that we won't get denials for care and things like that. But from CMS's standpoint, if a patient has care needs, those care needs should be met no matter what clinical category they're in. And I know that the clinical category titles, there are two of them that sound more like probably that would be more lined up with what is happening in maybe with certain patient populations, but just know that it doesn't really matter what the title of the clinical category is that the patient has been assigned to, except for payment. What's more important is what does that patient need? What's in their plan of care? Let's see. This next question is that CMS didn't, until recently, did not accept the CPT code for cognition for OT. So this person is saying that for years they did not use the cognition CPT code because it wasn't covered. And this is sort of mixing Medicare Part A and Medicare Part B again, but I understand that that happens in skilled nursing facilities. So there is a lot of frustration with the change. I know there was a recent change with the cognition code, and I'm not probably the very best person to be able to get into the details of that. We have a coding expert on staff, but for Medicare Part B, there is a cognition code. It changed recently, and we have information on our website. I think taking a step back, when I'm talking about cognition and that it's not included in the OT component, it's not specifically included in kind of like their formula that they're using. To me, that doesn't mean that you shouldn't be addressing areas that take cognition into account. A lot of interventions sort of more indirectly address cognition, and this is coming from a non-OT, so please bear with me, but I think that it's important to just identify what the patient needs, include it in the plan of care, address it, document it completely, report it, and we can hope for future refinements so that those are recognized appropriately in the future.
And Jen, can I just add in one maybe clarification that will help connect the dots here on this cognition? So cognition was not included as a component on how we would, what our OT's payment would be, based on analysis that CMS's contractor did. And what data did they use? They used MDS data from a few years ago, and they looked at the entire population of SNF patients, so Medicare Part A, across the entire country. If, you know, in the, I think the few years that they looked at, they identified if the cognitive items on the MDS were identified, and so having a more, a moderate or severe cognitive impairment as indicated by the MDS, and did that patient get OT services. And in their analysis, they found that when looking at those individuals that, as identified on the MDS, had greater cognitive impairment, was not predictive of receiving OT services, which tells us that those more cognitively impaired patients, as indicated on the MDS, were not getting OT services at the same level as some of our other patients that were not as cognitively impaired. And so that's where, again, there are some data limitations with the MDS and cognition, but that's where that came from in terms of OT and cognition not being a predictor, if that helps individuals kind of understand what data CMS was using.
Mm-hmm.
There is one question that I want to make sure I get to. It's about group therapy, and they're asking, the person is asking to explain the process of group therapy in terms of what practitioners will be, whether practitioners will be required to group Medicare patients, and what will payment look like for facilities. I mentioned earlier that there will be a combined 25% limit on group and concurrent therapy. So up to 25% of therapy that will be provided can be group or concurrent therapy. That means at least 75% of therapy has to be individual therapy. And the consequences of that are not totally clear yet. Technically, if a provider, if a SNF exceeds that level for any individual patient, they receive what's called a non-fatal edit. And so there were a lot of comments about that, and CMS addressed those in the final rule. And they basically indicated that they are going to monitor the utilization of group and concurrent therapy, and if they need to, they will address it in future rulemaking. So, you know, one of the reasons that we were so supportive of keeping that limit in place is for exactly the reason that this person is asking the question, is because are you going to be required to group all of your patients, get all your patients into a group? And that is not what we want. We really want to be able to provide individual therapy. And group therapy is very beneficial in some cases too, but we wanted to be able to have that, that individual level of therapy be the kind of more the norm. So that might be something that is, there might be changes in the future on that issue with group and concurrent therapy. If there is found to be abuse, I would expect to be, there would be consequences rather than just a non-fatal edit that would go back to the skilled nursing facility to warn them that they've exceeded that 25% limit for a certain patient. So probably more to come on that, but I do appreciate that question.
I have a couple of just general, I'm going to just take a second, Jen, to answer just a couple of questions that are kind of about the webinar and then the process of this, because I think I can lump a few of them together. We're getting questions as to whether or not we're going to be doing more webinars like this over the next year, and whether or not we'll be doing some specific training with clinicians, perhaps on documentation and different treatment ideas underneath the PDPM. And the answer is yes, we're definitely going to be doing more webinars like this. Part of what our desire was tonight was to really get this information out there, see what kinds of questions are coming in, and really be able to identify what what kinds of resources do all of our occupational therapy practitioners need to be able to be successful in really working to be able to show the value of occupational therapy in this setting. So this is really just that first start. And so if we don't get to your question tonight, there's definitely ways that we're going to be continuing to incorporate that in future webinars. And then just lastly, yes, there will be a replay of tonight's session. So this session is recorded. You'll get a link to it sometime at the end of the week, and you'll be able to re-listen to the entire session. I would encourage you to go ahead and share that as well, and inform people that you're with as well with regards to the information that you've learned this evening.
Okay, I saw a question that I think would be helpful for people to kind of get some perspective. Does the SNF get one lump sum of payment to spend how they wish? Who controls that spending? This sort of gets to the heart of what our concerns about having safeguards for patient access to therapy. The skilled nursing facility will get a daily rate for a patient, and they do have kind of the freedom to apply that how they wish. And now that therapy minutes aren't kind of the ATM machine of the skilled nursing facility, it might change a little bit, but it is really important to keep in mind all of those quality requirements and value-based purchasing requirements that Natalie talked about, that, those things are really critical. Reducing readmission, shortening lengths of stay is important for those preferred provider relationships. So it really is an opportunity to show the value of occupational therapy. And is SLP solely responsible for cognitive therapy in this new model? Speech does have a cognitive component in their, it's part of the speech component, and so it does show up in the way that the rate is determined for speech. But that being said, like I said, it's important that when things are identified in the plan of care, that they are addressed, whether or not they're specifically called out in the way the payment is determined. And so it's important that it be recognized and that OTs advocate for how they address cognition in a different way than speech. And I've heard examples of that in practice, and I think that it is very important at this time for OT to be stepping up. And I also see an opportunity, like I said, I know that there are new cognition measures being developed, and so we're looking for that as well, that we will be able to report those, get the data, and get added for cognition. There was a question about comorbidities not being included in the OT component. There aren't any comorbidities included in OT or PT components at this time. That is something that CMS indicated in the final rule that they will watch and maybe make future refinements. And so our hope is that it will be reflected that when a patient has comorbidities, their care needs are different, and there should be payment that is connected with that.
Natalie, do you have some questions that you want to be able to speak to?
So one of the questions goes back to cognition and how and where are the best places to document cognition. And this is really a two-prong approach that I would suggest. One, in your electronic medical records, while that may not go to CMS, when and if your facility is ever audited, they can look at that. From a CMS perspective, the data they will see is on the MDS. And so if you have patients who have cognitive impairments, as indicated by the different items on the MDS, if they have a need for occupational therapy, if you are delivering, your best practices, that will be captured through that Section O that OT was involved. So you're going to be thinking about it both from an MDS perspective as well as your clinical documentation. And there's a bunch of questions here. Some around Section Section GG. Does the SNF quality reporting program use data from GG to show the functional aspect of nursing home compare? Jen, do you remember if that's transitioned yet, or is that still in the process?
I think it's still in process. The CMS, there's some technical requirements where they have to have a certain number of years of data to use it. I think it's coming soon, but I don't think it's included yet. So it will be, and that's even more of a reason to be sure that everything is documented accurately and completely.
Great, thanks, Jen. The other part of the question was, how can we be sure that OT is completing the self-care GG codes and not CNAs and nursing? And I think that's a place where we can take action now and help change that culture if it's not already happening, and demonstrate to the rest of the team the value that you can bring by completing those self-care GG codes. Will the importance of assessment tools decrease with the increased focus on GG codes? So Section GG is for the MDS, but you are still going to be required to, through your daily documentation, be able to demonstrate that you're delivering best practice, that you are making clinical decisions based on standardized assessments and the best evidence. So just because Section GG is going to be part of how a patient is categorized for payment, that does not take away the importance of integrating standardized assessment tools to guide your plan of care. And then I'll bring up one question that I'm not quite sure actually what's being asked, and maybe the individual can write some clarification. What would be your rationale for an OT over an administrator RN to provide community discharge measures while holding your own caseload? I can try and define this community discharge measure. So CMS is using successful community discharge or community discharge as a quality reporting measure. And this is currently captured through claims data. So it's not necessarily that it's an RN or an OT completing it. It is something that is captured on the back end, where I think OT can demonstrate their value is thinking about what are the things that we need to do with our clients to make sure that they get home and stay home that 30 days. So the family caregiver training, empowering the patient, particularly if they live alone, to recognize the signs and symptoms if their functional status or their medical status are starting to decline. Do they have the cognitive capacity to manage their medications on their own? And if not, what cognitive strategies and other compensatory strategies need to be in place so that they don't bounce back to the hospital because they have some functional cognition limitations that are impairing their ability to manage their meds. So those would be some of the things I would think about. If I have misunderstood the question, feel free to clarify.
And I think, we have just a couple minutes that, Jen, do you have any last questions that you really want to be able to speak to?
One question was, if PDPM is replacing RUGs, will patients have a say in their daily session times? And I don't think that this is really, that issue is really addressed by PDPM, except to say that CMS is looking for patient-centered care. So, this is a hard one for me, not being an OT, to totally answer probably in a way that is fair. But I would say that CMS does expect care to be patient-centered, and if there are things that patients should be working on at certain times of the day, then that's kind of when they should happen. And it really depends on the workload of the therapist. It depends on the patient mix at the facility. So I think it really depends on each facility as to how they can sort of be flexible for what each patient wants. I don't know if that helps. I'm a little bit at a loss as a non-OT, but I technically that's not addressed in the PDPM.
And I would say, Jen, I think you sell yourself short. So while Jen may not be an occupational therapist by training, she is related to one. Her sister is an occupational therapist, and so and works in this setting. So bends her ear frequently, and so I know that you are very in tune to what's happening with practitioners and with clients in our skilled nursing facilities. So I just want to say thank you to everybody for all of the good questions. We got great questions. We got some really good feedback in terms of ideas that we might be able to use to be able to build off of this. You know, we really do want to, you know, hear from you what we can do to help to be able to facilitate practitioners to be able to showcase the role and the value of occupational therapy in your settings. So keep those ideas coming. I'd invite you, if you have things that you're hearing in your facility, or if you have ideas for resources that you think would be valuable, please feel free to send them. You can certainly send them my way at alam@aotaboard.org. And also, I know Jennifer, the regulatory at aota.org is also another good address to be reached at, correct?
Yes. Yep.
Perfect. So as we close tonight, I really want to emphasize this piece, and I can't take credit for it. It came out in discussion I was having with a colleague about this idea of doing one thing. And if each of us could commit to doing one thing in our daily practice to show the value of occupational therapy, whether it's articulating the distinct value, it's demonstrating it in our daily work, and documenting it in our practice. We need to really commit to that one action a day. And if we can do one thing a day to show that value, that we really will be able to have positive change as this payment system is rolling out. And I think that's the call to action that I'd like to leave everybody with this evening is go back to your facilities tomorrow, talk to people about what you learned tonight, commit to doing that one thing to show the value of occupational therapy, and then invite others to come along with you and to do the same thing, because that's going to be really instrumental as we solidify our place within this new payment system. So thank you, everybody, for giving us your time this evening. Thank you so much to Jen and Natalie for your expertise on the call this evening, and we look forward to connecting again next month with all of you on the next Member Appreciation Plus call. Thank you, everyone. Have a good night.
Bye, everybody.